Good morning, everyone. I'm delighted to be here. So I'm going to be even more selfish than Chuck described in that I'm going to talk about the journey of quality measurement, but all through the Mass Health Collaborative lens. So you're going to get to just sit back and follow this very gripping story I'm sure you're going to find. Hopefully you have a lot of coffee. It'll keep you awake. But one of the things I want to point out is, just sort of in the trenches, what does it look like over the last 10 years of, sort of embarking on quality measurement from, really we started in 2006, 2007, as I'll describe for you. And things look a lot different than they did back then, but a lot of it still looks the same, actually, in the trenches. And I know everyone here, and we've all been focusing on, what we might think of as, sort of a little bit of rocket science of, how we're going to fire enable this stuff and being able to, sort of have fire APIs that are going to do all this stuff and CQL and, all of that great stuff, and that's fantastic. But, I will just sort of point out, and I think as you'll see in my presentation, a lot of what's going on the ground, and many of you know this, but I think it's worth reminding ourselves of this. It's still, and here we are in the anniversary of Apollo 11, this is still, John Glenn hoping to make one more orbit, around the world in that little Gemini capsule before he crash lands. And that's a little bit of, where we are today. And there's a lot of hope, and I, as Chuck said, I'm very involved in fire, and I have a lot of hope of, what that's going to help us do. But it's going to be, sort of a second or third journey before that's really in production and things that we can really count on. And we've got to count on a lot of, sort of wire and baling, until then, unfortunately. And but it's not negative because, as you'll see, at least we're a small organization. We've been able to accomplish a lot. I know a lot of larger organizations have been able to accomplish a lot as well, but it takes a lot of work. So this is the only picture of me, I promise. That's me, actually. If you didn't notice back there, I'm hiding behind Senator Kennedy. You may wonder why I'm showing this picture. This was the launching of the Mass Health Collaborative in 2005. We are a nonprofit organization, and Mitt Romney and Senator Kennedy, were a part of the launching of the organization. And the fellow right to my left, as you may know, is Dr. David Brailer. He was the first national coordinator for health IT. And they had just launched the National Coordinator's Offices in 2004, 2005. They had $50 million, or $52 million, I think was David Brailer's budget at the time for the entire country. And we had the good fortune in Massachusetts to have $50 million to launch this pilot project, which is partly why he came up. He said, I want to come up and see what you're going to do in one state with $50 million, because I can't, for the life of me, figure out what I can do across the country with just $50 million. So we had a collaboration. It was really Blue Cross Blue Shield of Massachusetts who committed to making a $50 million commitment to some type of initiative related to health information technology, and partnered with the Massachusetts Medical Society and the Massachusetts chapter of the American College of Physicians, really with the primary aim of figuring out how we can accelerate adoption of electronic health records, health information exchange, and quality data analytics, electronically sort of based quality data analytics. And for all of us, especially here in Massachusetts, we've got to sort of suspend your disbelief and project yourself back to then, when it was a pretty barren landscape in electronic health records. The hospitals had electronic health records, most of them custom-built EHRs here in Massachusetts, and and the leading organizations across the country as well. And on the ambulatory side, it was barren, and we had no idea how this was going to get done, right? And this was looking like, wow, this is going to be a 30 to 40-year exercise in just, sort of hoping that people sort of see the vision and are able to do it in the most fragmented and complex part of our economy, right? So it was a real challenge back then, and that's partly why Blue Cross said, we need to see if we can move the ball on this. So we launched the organization, nonprofit, based here in Massachusetts, and one of the things we did is we said, all right, with $50 million, we're going to launch 3 pilot projects. And so we had put out a request for proposals to markets in across the state of Massachusetts. Mitt Romney made that announcement for us, which got a lot of attention, as you can imagine. And the red dots represent the markets that actually applied, and they applied to be one of what we said would be 3 communities who we would wire for healthcare. And of course, we had no idea what we were talking about any more than we would today if we said we're going to wire you for healthcare. But we just sort of said we all need to just jump into this together and try to figure out how we can use off-the-shelf solutions to move the industry forward, at least in these 3 markets. So we ended up choosing 3 markets: Brockton, Newburyport, and North Adams. And the program was to provide electronic health record systems to 600 clinicians in 200 practice locations, stand up health information exchanges, one in each market, and then create a data analytics warehouse at the top of that. So you may be wondering, why am I telling a story? It's really about that, right? That's what we created back at that time, and then I'll kind of describe for you how that's matured over the years, because that's now still it's a full production commercial warehouse. So what we did is, we implemented electronic health records. We paid for 4 systems: NextGen, Allscripts, GE, and eClinicalWorks. Very, very painful process, as you might imagine. Stood up 3 health information exchanges, and then we built this data warehouse, on top of all of that, that extracted the clinical information out of the health information exchanges that we had stood up. And the original idea was that would just be a research platform for Dr. David Bates and his team from Harvard Medical School to be the evaluators and, and do some research on the pilot projects. But as you can imagine, those 600 clinicians who were participating, the subjects of the experiment started asking questions like, how come we don't have access to that data? Why don't you make it available to us so we can start thinking about, how we can improve performance? And to me, it was like, wow, I wish I had thought of that. I mean, that's a great idea. So that's what we started working on is, how to make the data available to the provider organizations. Again, this was before, real value-based purchasing or, the kinds of, quality measurement that we have today and the kinds of, value-based or, quality measurement tied to payments. But the good thing is, even back then, they wanted to have that information. They were wondering, how am I performing? How would I even know if I'm doing, better or worse? So we, did a bunch of stuff. There were a bunch of studies and all of that that came out of it. But what we ended up doing was standing up this data warehouse, this clinical data warehouse, on top of that. And this is a slide from 2009, I think. And as you can see, we were crowing very proudly about having 57,000 records received in our warehouse in the month of May 2009, and we've broken it up by community. And I was really happy. I thought, wow, 57,000 records, amazing. And so we just kept on plodding ahead, kind of building that warehouse and seeing what we could do with it. And then, we, kind of matured, because one of the things that happened, is the pilot projects ended, and we were actually thinking of sunsetting the organization, but we started to get demand for the data warehouse capability and for some of what we now call regional extension service capabilities, the people who work in provider settings, helping them adopt and optimize electronic health records. So we decided, all right, well, let's pivot, and we'll just do that as a fee-for-service, kind of thing. And one of the things that we quickly found was, we need to upgrade, sort of the standardization of this data warehouse, which we really just put together as this custom kind of thing with, custom interfaces. And we need to start thinking about, certification. Meaningful use was on the horizon, ONC certification, all of that. So it's now a QCDR, it's meaningfully use certified, hospitals, ambulatory, blah, blah, blah. It's got all of that. And that was one of the things that we ended up having to do. And then we, got a lot more customers. So got a ton of different customers who, are now using the warehouse. And you may think that that's very odd, right? For a small organization, we're 20 people, about $6 million a year, nonprofit organization based in Massachusetts. And we've got all of these customers, sort of using the data warehouse for, for various things. And I'll describe to you in a second, how that, sort of came about and what some of the challenges have been, along the way and continue to be, and what that, sort of says about where we might head in the future. And as you can see, there's a real odd mix of customers in here as well. You've got provider organizations, ACOs, Public Health Commission. How do they all sort of fit together into a data warehouse strategy? So in terms of, the scope of it, so that's a bunch of customers. In terms of the scope of it, just reminding you, and I said before, we had 57,000 records in the month of May 2009, and now, in 2019, we're right now, as of July 7th, we're getting 350,000 records a day from provider organizations across the country. And that's in continuity of care documents, CCD payload, flat files, in real time or near real time. So the scale of it has, increased tremendously. But there's been a ton of hard work, and that's a little bit of the challenge is, that every single one of those feels like it was manually wrestled to the ground, and very, very hard to scale. So, the challenge is that, we're one small organization doing that, and every single organization who's trying to do this is doing the same thing, right? And that's, that's the sort of the hurdle that we want to get over, but we have a little bit of distance between now and then. And we also, face the regular, sort of a spectrum of EHR vendors that, that all of you face as well as you're trying to do this. And we have the same issue, 40 plus, 50 plus EHR systems, some of them within a single ACO. They want uniform analytics. They've got 40 different EHRs. How do we sort of solve that problem for them and do it at scale and do it in a way that's, that's not going to be, outrageously expensive so that they actually can't get the real work done that they want to get done. So we ended up discovering a few things along the way to sort of building that thing, and we're obviously still learning. But a few things that we discovered is, one is that this does work, awesome, is that we just, sort of came to appreciate how much of an end-to-end process this is. And we started focusing, we at the beginning we thought, all right, we're going to focus all of our efforts, here, right? A lot of the analytic stuff. How do you build a warehouse? Are we doing the most efficient, DBA kind of stuff, and and all of that? And then it turns out that most of our effort is and continues to be over here, right? It's on data quality. It's data quality, data quality, data quality. We don't have a day where we're not thinking about data quality and how to resolve those issues. And very little effort, I mean, I shouldn't say very little effort, my developers would kill me if I said that, but if they heard me say that. But if you think about the overall time we spend a lot of it is down on this end of the spectrum. And so, we've really, so that's one of the lessons I wanted to, I'm going to dive down into a little bit here and describe for you the kinds of, sort of really manual or semi-automated things that we do to make that happen because, the world isn't quite where we need it to be right now. The other thing that we ended up learning, which was a hard lesson, and I'll describe a little bit more, is that we ended up having to build a manual data entry abstraction tool into the data warehouse, which was shocking to me that customers wanted it. And it was some of our biggest and most advanced customers who approached us and said, all this electronic stuff is great. There's still gaps. We need a manual data extraction tool to fill in those gaps because we're now on the hook for these measures. This isn't like meaningful use where whatever your numerator is, no one cares as long as you have a numerator. This is like, no, 3 percentage points actually will get us a $50,000 bonus. So we actually need a tool to be able to, supplement the data that we have. Surprising to us because we were pushing down the road of no, everything has to be electronic. Let's sort of refine and get the best interfaces possible and work with the vendors on those best models. And then we realized there are structural barriers to us to our being able to get all of it electronically, and so we need to be able to build that tool. And I'll describe that for you as well. So that was another sort of big lesson learned. We do have a Fire server, I'll just point out here, I'm not going to spend a whole lot of time talking about it, where we take data in, we can take CCDs in and expose it as Fire servers, and I will tell you it has gotten zero attention from the market, except for testers. So Apple tested the iPhone application before they launched it. They used that server to do all the testing of the iOS 11.3 Apple Health record for the de-identified records that we make available there. But no one from a production perspective has ever asked us, even though they're very aware that we have that Fire server, has ever asked us to use that for anything, which I think gives you just a sense of where are we in terms of the state of the industry. That it's still very novel, it's still experimental, most of it for patient-facing things, and definitely not scalable yet. And we're working hard to make it that way, but we've got a lot of work ahead in that front. So let me dive down a little bit into showing you some of the details on that. So first thing is, what about data formats? So one of the things that I didn't sort of talk about is we end up having to take what we want to do is say we can just leverage CCDs, right? Let's just do it that way. And there are a lot of companies and a lot of organizations out there that'll take more of a database, ODBC, SQL queries against the database. We, as a strategy, just said, we're not going to do that. It has all sorts of issues that we don't want to get into, and I'm not saying it's wrong or right, it's just a strategy that we decided we're not going to do that. We're going to really leverage CCDs and the CCD construct and try to do it that way. And so, in 2018, we got about 65 million records from all of our customers. And as you can see, 85% of those records actually come to us as flat files with CCD payloads. So CCD payloads, and some of them may have sent us CCDs, but then they said, our vendor charges for CCDs, and CCDs are so hard to work with, and can we just send you a flat file with the CCD payloads? So we ended up having to, sort of scale a flat file specification for all those different customers all over the place to have them, be able to push to us, flat files. We do leverage the CCD, and the CCDA and the CCDA payload. I mean, we use that as, sort of the construct. But just to give you a sense of, the variation that you end up finding, and as you can appreciate, there's a ton of variation. within each of those categories, right? Each of those CCDAs, is a little bit different, and the flat files certainly have, a lot of variation that we end up having to manage. So that's sort of an ongoing challenge. The other thing we end up having to do is a ton of data validation. So we'll work with, so one of our customers may say, we're launching an ACO in a particular state. They have 15 different EHR systems. And then we'll come in and we'll work with those EHR systems to start to extract that data. Some of it is about, all right, what's the form and format of the data, all of that, and then we'll have a big data validation step, and then we end up having to have, a set of semi-automated processes just to validate the data, because what we find is that it varies by practice, not just by EHR system. So it varies by EHR system, eClinicalWorks versus Athena, but then within eClinicalWorks, you got 5 practices. We end up having to do one-time data validation for each one of those practices because we find more variation actually across practices than we do across vendors. So that ends up being, a pretty big lift and one that usually surprises customers that we have to spend that much time. And so we have a set of, automated tools, semi-automated tools, I should say, that do, sort of data analysis. They do frequency analysis reports. So it gives us an analysis of every single code that we've gotten from those systems. And then we start to say, let's look at the frequency analysis of that because nothing's ever fully standardized. And then let's work with the customer to sort of give them a data quality view and then help to think of really tactical, practical ways that we can start to resolve some of the issues. So for example, what might be one of those issues? You might get, sort of a frequency analysis that shows a bunch of coding, all of which looks like it's HbA1c, but there's some variation there, and there's some weird stuff. It might be, say, HB, it might say, glycosylated hemoglobin, whatever it is. And then we'll look at it and we'll say, well, this looks like it's really coded. There's a bunch, 5, 6 different ways they're representing this. Doesn't look like that's, it looks like that what they intended was that coding, and then we'll, sort of take some practical steps to say, what, but 3 of those, the frequency is like less than 1%. So forget it, who cares? Let's not worry about the mapping of those, but 2 of those actually look like they would map to that, and we can solve that mapping on our end as long as we understand from the provider that that's what they're doing, and those are 20% of what we're getting. Right, so that's very, sort of practical. We decided from the beginning we're not going to take the strategy of let's try to normalize everything because that's a never-ending game that we'll never get out of, and the customer actually only wants some subset of all of the data that's coming in, so let's focus on the subset that they need and what's going to get them the best performance measurement at the end of the day that's going to make a measurable difference for their payment contracts. So we end up, because we don't have the resources, mostly because we don't have the resources of saying, how do you get just hopelessly practical around some of that stuff? So what does that mean? That means that, for every single practice, we'll deliver this kind of sample data quality report. And this is a real report. I've just taken off the names, and it shows them, measure by measure, what we're getting in terms of, what your performance rate looks like right now, what your electronic data status looks like, which is our assessment of how much of that gap we think we could probably fill with a little bit of remediation, and what are the things that we think are probably issues that are source system issues, meaning it's a documentation issue at the practice, or the EHR doesn't have that field yet, or there's something in the interface, so we're not getting that data. It's not a mapping thing that we can solve. And so then we'll divide that world into, here are a set of things that are issues. We can resolve those on our end with some mapping. Here's a whole set of issues that someone needs to go back to the practice and talk to them about, sort of how we're going to remediate some of those things. And some customers are diligent about saying, okay, that's great, I'll go back. Others, as you can imagine, say, oh, I don't want to bother them. I was hoping this was all going to happen in the background, and they're not going to be bothered, so let's not bother them, and we'll just fix what we can, on our end. That presents gaps at the end of the day, but that's just a judgment call that that they're going to make. The other thing that so we end up doing data normalizations, and this is some of the data, and it's a little bit distorted in a sense, and I'll describe that in a second. But I wanted to give you a perspective on what are we finding in terms of, well, where do we end up having to do more normalization, and where don't we? Which gives us a perspective on are there sort of data type variation in terms of the ability to have things sent in a codified way versus where do you see more variation. So if you can't see it in the back of the room, I've just sort of said procedures, social history, immunizations, medications, and what I've shown here is for all of the data elements that we got. So in 2018, I showed it was 64 million records that we got. That actually translates into 2.4 billion data elements, right? Because each record has got all sorts of data elements in it. And so that's 2.4 billion data elements that we got. And then I asked the question, what percent of those data elements for each of those categories, for what percent of those did we actually have to do normalization on our side because it came through in a non-normalized way? right? So that's, that's kind of what that looks like. Now you may look at that and think, wow, the percentages look really good. You're getting most of it normalized. One caveat I would have is that denominator is deceiving because as I said before, we don't try to normalize everything. So what we're looking at is you've got a set of measures that you want. Let's map all of that to data elements that are required for those measures, and now we'll only focus on normalizing the data elements that are implicated by those measures. This, unfortunately, has the entire data elements, all the data elements as a denominator, so it's a little bit distorted. But it does show you that, we seem to have greater issues with procedures, amazingly, right? We have lots of variation in what we're getting with procedures. Social history won't surprise you, that's less codified, a lot of free texting, a lot of weird stuff coming through in there. Immunizations and medications, but immunizations is the other weird one that we get, lots of weird variation, coming through in immunizations that we end up having to, sort of map on our end. So, many of you may have different experiences in this, and I would love to talk about that, but I just wanted to give you a perspective on, how we're trying to look at it and trying to sort of figure out, well, are there things that we can figure out at a system level that can help to resolve some of these issues and can help inform us as well as, help inform others, vendors and ACOs, in turn, to be able to, sort of say, how do we wrap our arms around this and get better at it? The other thing that we ended up finding is that we had to build this manual data entry portal, as I described. Now, you can see, we're a small nonprofit organization, so we don't spend much time on user interface. So it's not the prettiest thing in the world, but what we've basically had to do is say, here are the measures and your ability to manually come in and supplement the data. Now, we'll pre-populate it with whatever we get electronically, and then we'll allow them to come in and then manually supplement that data and include it in there. Again, something that I never anticipated that we would ever have to build, but it's getting a lot more uptake than I ever imagined. It was also more complicated than I thought. It was one of those things where I went to a customer and said, yeah, sure, we can do that. Came back to the development team and they were like, you said what? And then 6 months and $100,000 later, it's like, oh, okay, here it is, it's done. But now people are really happy with it. And one of the things that it's given us actually, which is an unintended consequence or an unintended benefit, is as we move more and more into the social determinants of health space, you've got organizations who don't have EHRs. So we're able to customize this to allow them to come in and have secure access, and the YMCA or social services organization be able to come in securely, put in information that gets commingled with all the other data, since they themselves don't have tools and they're happy to come into a portal, unlike a provider organization that doesn't really want to come into a portal. So it's very odd that we end up doing this, but we have customers during GPRO reporting period that will deploy this across the country to 1,000, 1,500 users in provider organizations, and during the GPRO period, they'll bang away at this and supplement their data to try to get as much improvement as they can in their scores. Shocking to me, one of the realities of what we've had to sort of create. The other thing is we ended up having to create a dashboard, and I know you can't see this, but the dashboard, because one of the challenges that we also found, as soon as every time you create something, then someone says that's great, but what about, it's like, oh, okay, yeah, I guess that's an issue. So we create this thing, and they said, well, that's great, but we can't do manual abstraction for everyone. I mean, how do we know? Where should we do it? Where shouldn't we do it? We have limited resources. We're not going to do manual abstraction for every measure, for every practice. They're all across the country. And so we said, all right, well, we can create some kind of dashboard that gives you a sense of where are you close. And what I mean by that is, I know you can't see this in the back of the room, but on the left-hand side there, what you have is the different measures, and what we show is, here's what your preliminary performance looks like based on the electronic data that we've got. And so you're performing at 63%, let's say. And in your contract, you've got a threshold at 65% that's going to give you some significant non-trivial bonus. Well, we're able to show, 2 percentage points on that particular measure, where in our experience, we've found there's probably a lot of free text stuff just hanging around in the EHR that never got structured. Might be worth sending some people out to those particular practices, and we can identify which ones look low, to do some manual looking to see if you can just boost it up by 2 percentage points. Versus, you're at 50%, the threshold is 65, manual abstraction is never going to get there, don't worry about that right now. Now, obviously, we all want to keep improving quality on everything and improve the data, but everyone has to make practical decisions around, some of the payment models, right? So that's, kind of what they use this tool for. So we're able to sort of show it by patient as well. So you're able to say, well, gee, by patient, where along every one of those measures What status are they in? They look like they failed. They look like they passed. It's been a confirmed pass. Someone has actually gone in and confirmed it. And each organization has a different way that they want to be able to confirm that. But again, not to show you it as a whiz-bang thing, but to show you it as, wow, there's just a lot of manual labor that people still end up having to do to be able to perform well against these contracts. And that's a little bit of the painful reality that at least that we're facing. And maybe we could be better, but that's what we end up having to do and roll out to our customers. So one of the things, again, an unintended benefit that we found of this manual data entry portal is that we were able, after we got a couple of years data, and it's only been live for a couple of years, so we're just at the beginning of this, we're able to start to ask ourselves, well, what % of the data that we need actually comes in electronically, right? Before, we didn't know because we didn't know what the denominator was. It was like, well, I have no idea what data I'm not getting. All I know is what I'm getting. But once you had the manual data entry portal, you were able to ask yourself, oh, from a customer perspective, what % can they rely on us to do it electronically versus, no, I have to hand it back to you or someone to go and do the manual intervention. And there's some surprising results that we're finding from some of the preliminary analysis. And this is very preliminary, so would love your thoughts on it as well if you have looks at it, because we're just starting to look at this data. As I said, we only have a couple of years of data, so we're just looking at it. So one was, I looked at, here's a smattering of ACOs that we support. And these are different ACOs and different geographic regions, each of them with a different mix of electronic health records. And what this chart shows is the % by the ACO of all the measures. So it's all the measures that we're measuring, and I'll show you the measure view in a second. And it shows you the range by measure of the % that's fully automated, meaning we were able to get all the data that we needed for that particular measure through an electronic mechanism. We didn't have to have manual abstraction. And it shows you the min and the max. And what surprised me was the variation you see, right? That, for ACO, so what does that mean? For ACO 22, they had some measures, or at least one measure, that was only 30% of the data was coming through electronically, and they had to find 70% of it through other means, through manual means. And there was another measure where they were actually able to get 90% of that data through our electronic interfaces and everything that we've done electronically, and they only had to fill the gap with 10%, right? And so one of the things that surprised me was, wow, there's just a lot of range. And then you can sort of think, well, all right, some measures have less codified stuff, some don't. All right, so maybe we'll sort of see that in the next view. There's also, you can see variation across the ACOs as well, right? So there's something else going on here, obviously. There's different EHR mix, there's different training, there's different support from the ACO staff, right? All of those things come into play, and that's the part that we haven't, sort of teased out yet. What are those confounding variables, and then how do we, sort of do the multifactorial analysis that allows you to say, well, which of these factors seems to be the biggest one? But that's like, the first look. When you look at it by measure, so then I thought, well, when you look at this view, surely what we're going to see is that with some measures, it's a lot tighter because anything that's based on a lot of structured data that performs pretty well, labs, meds, whatever that is, those measures you probably see really narrow band. And with some measures that anything that implicates social history or anything like that, you probably see something really wide because there's a lot of opportunity for free texting. Wasn't what we found, actually. When I break it out by measure, and now the range is ACO1 to ACOX, and I do it by measure, I still see variation. Right? I still see some ACOs for that measure still have a low % electronic, and then some ACOs have a high % electronic for the measure. So clearly it's not about the measure necessarily, right? There's more going on there. There's something more going on there related to the combination of EHRs, training, whatever ACO enablement is there, because different ACOs do different things, as we know. And so again, I'm not pretending that I have any answers to these, and this is just the first look at the data, and again, would love any of your input on this, because most of you are more expert at this than me. But I sort of found this fascinating, and also sort of a window into, well, where can we tighten things up, and how do we need to sort of drill down a little bit more to identify what are the real issues here in being able to scale this, and then how can we sort of think about what those solutions look like, not only from a standards perspective, but from a process perspective as well. So what has that led us to? It's led us to a couple of other sort of projects that have allowed us to build on what we're able to do today. And by we, I mean the industry. I'm not talking about just the MassDL Collaborative. I'm talking about the industry. And that's a part of sort of the journey that all of us are on. So we've got a project going on with the Boston Public Health Commission where they, in 2006, Yes, 2006. They promulgated a regulation where they said that, and I'm just going to check my time here for a second. Okay. They promulgated a regulation that required every hospital and every health center in the city of Boston to send race, ethnicity, language, and other clinical data to the Public Health Commission so that they can start to measure health equities. They had some high-level data based on claims, based on other public health information that was suggesting that there are serious inequities based on race, ethnicity, language, and the provision of care, right? Not surprising. And to their credit, they said, we're going to step forward and we're going to do something about this. So one of the things we need to do is get the data, then we can do that stratification, and then we can figure out how do we need to reallocate some of our public health resources to try to address some of those, and perhaps with an eye towards some public reporting to sort of show how the provider organizations are doing on these measures. Well, they promulgated that in 2006. Went almost nowhere. Why? Because no one had EHRs, or all the EHRs were custom, and there were no standardized measures, and right, not surprisingly. So it was a great idea. They started to get some race, ethnicity, language data, but it was very shallow, right? Then in 2013, they kind of dusted it off and said, people have electronic health records now, or they're soon going to. Maybe we should revisit this. So they promulgated this regulation, 250-page data spec, custom measures, loosely based on the continuity of care document, none of it related to what meaningful use was requiring with respect to continuity of care documents and populating them for transition of care, any of those kinds of things. The common clinical data set didn't really adhere to any of that, and they got a ton of pushback. So they promulgated this, rolled this out again and said, hey, great news, we're gonna roll this out. And they got, no way, we're not doing this. So came back to the table again and they said, okay, we actually will rethink this. And some of the feedback they got was, A, do this based on what providers are already doing in their offices. Meaningful use, continuity of care document, common clinical data set, CMS measures, right? Build what you're doing on that and you'll get a lot more acceptance. And the other thing, the other piece of feedback they got was, don't do this in the Public Health Commission because we're not sure we are confident that you've got the ability to do this at scale, that we've got all the security things, the city has sovereign immunity. If something goes wrong, we can't sue you, we're left holding the bag, because this is all patient-identified data they were talking about. So they came up with a model that said, all right, you need to go and hire a trusted entity, and you need to align this a little bit more with, what the national industry, where the industry is headed. So these are the organizations that are required to submit data. And we ended up winning the contract to provide that data warehouse. And it's not up and running yet because there is still, it'll shock you to know, there is still angst and a lot of, politics to navigate in terms of making this a reality and getting everyone's, comfort level around it. But it's now being restarted this year where every hospital in the city will be required to send a post-encounter CCD to this data warehouse hosted by us. We have business associate agreements with all of the hospitals, and then what we do is we pseudonymize the data, we calculate the measures, we match the patients across the provider organizations, pseudonymize the data, calculate the measures by provider organization, and stratified by the race, ethnicity, language categories that they want, and provide those calculated results to the Public Health Commission. So the Public Health Commission themselves are never in possession of or have access to patient-identified information. It isn't HIPAA de-identified because it is pseudonymized so that you could re-identify a record, but that provides enough of a buffer, at least from the provider organization's perspective right now, that says, okay, we can live with that model in fulfillment of sort of this public health mission. Now, I'll report to you next year on whether this actually happens. We've been at this for 2 or 3 years, and the technical infrastructure is built. This is not, again, it won't shock you to know this is not a technology issue at all. But one of the lessons here is by refocusing, so what I didn't mention is they also refocused their data requirement to completely align with the industry standard continuity of care documents and chose measures from the meaningful use measure set. So they basically said, all right, here's what we'll do. We'll basically say, here are the measures that we think may be more susceptible to health equity issues, and we'll base it on the CCD construct as it lives in the market today, and let's roll that out. And they got, not surprisingly, they got a lot more acceptance, a lot more uptake, and now we'll see how that goes in production. But that ended up being a lot of work, and again, one of these challenges of you think the standards are going to solve everything, and then they end up having to solve all these other kinds of problems. The other place where we're working is in New Hampshire with the DISRIP program, where one of the things they're doing up there is they're focusing on substance use disorder and behavioral health in particular. And so they've got this set of measures, some of them custom to New Hampshire, some of them standardized, a whole mix, some of them, hybrid HEDIS measures, some of them full clinical, some of them claims-based, and this reporting profile, and they've got 7, they've carved up the state into 7 what are called IDNs, each of them responsible for delivering measure results along all of these measures, and we're the data aggregator for those. And one of the challenges that we face there is that some of these measures are completely New Hampshire specific. A consolidated core assessment covering 10 social determinants of health domains like legal support, food insecurity, transportation insecurity, all of that. Each of them having to, all the provider organizations, 75 of them now submitting data, each of them having to do that in a custom way and then be able to represent that they've, somehow fulfilled that and be able to report that to the state. And from an architecture perspective, in this case, the state has us collecting clinical data out of those systems, providing them with the clinical data so that they can calculate the hybrid measures rather than having us do it. The reason I point that out is, also, as I'll show you in a second, Massachusetts has just rolled out their measure program for Medicaid, and it's the exact opposite. They actually are pushing the organization who they're going to hire to calculate those measures. So you've got completely different architecture, different measures, and as I'll show you, a different approach to how data, sort of transport is going to work. So that's been, sort of a challenge. One of the things that we've been able to do there is roll out that manual portal. Is to just say, all right, we don't have any good solutions for this. Let's roll out the manual portal. One of the things I'm going to come back to is where FHIR could have helped here is you've got this Common Core assessment that is a New Hampshire-specific thing. What we would have loved to have been able to do is say, we'll create this as a structured questionnaire that's got weighting, and it's got hierarchy in it, and it's got a little bit of adaptive behavior in it. And we'd love to be able to just roll that out as a FHIR resource to all the Epic sites, all the Cerner sites, all the Allscripts sites, have them consume it into their application. Everyone's looking at the same questionnaire, rendered however that vendor renders it, collect the data, and then push the data back out. Ha, 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 right? We couldn't do any of that. Every one of those is a custom, sort of questionnaire build, and we quickly realized, even in a state like New Hampshire, that's never going to work in a million years. So people are basically using paper forms, even though they're on very good systems. A couple have been able to do the custom forms in their EHRs. Most of them are using paper forms and then representing to us on a spreadsheet or some kind of flat file that yes, yes, we did that. We've got a questionnaire implementation guide that the Argonaut project has worked on that once implemented would help to facilitate that, but we're pretty far away from that being sort of uniformly made available on all these EHR systems. But that's a little bit of the hope of the future, and one of the use cases for that is being able to do that. The other thing that that I was describing, and one of the challenges, and this isn't a criticism, it's just the reality of how this is working today. So a short 60 miles away, I just described to you what was going on in New Hampshire, and now here we are in Massachusetts. Massachusetts just rolled out, they put 80% of patients into value-based purchasing arrangements. 17 ACOs are now responsible for those 80% of patients, and they're just rolling out their measure program right now. And as you can see, it's from March 2019 is what they're describing, and their measure program is based on Excel. It is like an amazing, it's like one of the greatest uses of Excel in the world, what's going on with Massachusetts quality measurement. So they've got Excel sheets all over the place, and as you can see, they're going to be rolling out Excel sheets, one tab for each measure, rolling that out to every one of the ACOs, telling them, here, manually fill out these spreadsheets. Oh, by the way, remember in your submission package, you have to codify that, according to your file status. Make sure that you follow our file naming convention on each one of those files before you send it in, or it's going to be rejected. And that file naming convention changes with every month, remember. And that's, sort of the basis of how we're doing it. And again, I'm not doing this to make fun of people. I'm just saying that that's the state of the industry right now. And this is rolling out now, right? This isn't like pretend, or this isn't like something that was 3 years ago and we're just at the tail end of it. This is something we're at the beginning of. This is what they're doing right now. And they just put out an RFP early this year for a vendor to come in to upgrade this to what? A manual portal, so that people won't have to use Excel sheets. They can come into a manual portal and type their information into the manual portal. Right? So that's the reality of where we are for the next 4, 5, or 6 years here. And as I described, one of the challenges also is we just have New Hampshire 60 miles away who have a different architecture different set of standards, different approach to it, and just a fundamentally different architecture as well. Who's calculating those hybrid measures? Where do I aggregate the claims, the attribution files, all of that, and then who's responsible for that? So it makes it very difficult to scale once you sort of think about how you're going to do that across the country and in all these different settings. Every one of them is custom, unfortunately. So I have a lot of hope, even though I was just describing to you, sort of the challenges on the ground, because everything I was describing to you, we couldn't have done this even 5 years ago, right? So, we're able to do that today, and FHIR presents opportunities, for us to be able to do this. And one of the challenges, though, with FHIR is that it is, sort of an n-dimensional thing. You can do lots of things with it, and the challenge for us in a very fragmented system is how do we get enough people doing the same thing so that you can actually scale it? Because if everyone goes off in their own direction in FHIR, well, we still have this issue of, oh, geez, I still have to deal with Epic's Dartmouth-Hitchcock version versus Epic's Partners version versus Boston Children's Hospital Cerner version, right? I still have that same issue. It's like, okay, well, it's an upgraded standard, but the work is the same. It's just a different standard, right? So how do we, sort of get to a better place on that? One of the great things about FHIR is that we've got a ton of uptake and enthusiasm for it, and to the extent that we have commonality, to the extent that you have an Apple that's able to come in and say, you know what, I can roll this across the country so that you can download your records on your iPhone, is all because we have federal regulation through Medicare and Medicaid that has required one small piece of what's possible in FHIR and has said, everyone has to do this. And that's what everything that we've done in FHIR is kind of leveraging that right now. Why? Because that's what you can count on across all those systems. That's what Apple can count on when they go to Cerner and Epic and Allscripts and eClinicalWorks. They can say, I know they've got that. The rest of the stuff, I don't know, and I can't count on it. So not surprisingly, you can't get any of that other stuff in your iPhone. And not surprisingly, if you're going to think about doing this for quality measurement, you can't count on that across the industry every single time. You have to sort of think about, well, where is the industry on all of this? And so there's a lot of effort and work on the Da Vinci project, the Argonaut project, the Karen Alliance, different sort of initiatives right now, so-called FHIR accelerator projects, to try to say, how do we get collaborations that move all this forward together so that when you see that implementation guide and this collaboration of vendors and providers have sort of said, let's all agree that we're going to sort of do it this way so that you can start to scale this. But I will just caution that until an organization with the authority and the scope of the federal government makes it a requirement, from what we've seen so far, that's the only thing that makes it a requirement. Everything else, there's no payer who's big enough, aside from Medicare and Medicaid, who can drive the industry like that. There's no vendor big enough who can drive the industry. There's no provider organization who's big enough to drive the industry. And as we've seen, Medicaid is fragmented across the country as well. So that's a lot of the challenge that we still face with FHIR. I hope you weren't thinking that FHIR solves all issues. It doesn't. It just solves one particular set of issues, but we still have these other issues that we still have to address. Last slide, and just to give you some, a sense of that, is if you look at what the EHR vendors make available today. This is today, so this is what they publish. This isn't secret information. This is all available on their public websites, and it shows what APIs they make available today and what type of functionality, read versus write, read and write, whatever it is. And as you can see, there's some commonality, which is great. That's that little red box that I was showing you, right? That's what, the National Coordinator's Office and CMS has said, you have to make this available as an API, they said, and then the upcoming rules, the draft rules if they get finalized, it'll say it has to be a FHIR API. So that's the little red box. But then you see variation. And why do you see the variations? Because every vendor after that says, well, I've got my own roadmap based on what my customers say they want. And my customers are different than Cerner's customers, or my customers in California are different than my customers in Boston. And so each of them then goes off in their own different direction, not because they're stupid or selfish, but because they have different customer needs and different voices, at the table, sort of telling them where to head. So that's a little bit of the challenge as we think about, what we want to be able to do, because as you can see here, there's a lot of variation. This is just across the major EHR systems. When you look at the tail, it's even more varied. So in summary, I am really, really hopeful about where this is all going to get us, because there's tremendous energy around it. And as I said, there's folks in the room who are involved in the Da Vinci project that's focused on sort of payers and has use cases around quality measurement, which is fantastic. But I don't want any of us to lose sight of the fact that we've got a long tail of the stuff that we do today that's going to exist for for a while. And we can't, sort of lose sight of that if we want to keep making improvement, and we can, I think, as I've, hopefully showed, but it just takes a lot of work, and we shouldn't, the last thing in the world, I think, that we have the luxury of doing is saying, let's wait for fire. Because we can't wait for fire, because hopefully, as I've demonstrated to you, it's going to be a little while, not for any reasons related to the specification, but because of the industry and the fragmentation of the industry. It's going to take a while for us to be able to rely on things that are based on more modern internet conventions for us to be able to solve that problem. So bad news is you have to keep doing the hard work. Good news is there's hope on the horizon. So I very much am very grateful for your attention, and I hope this is really helpful, and I would love to sort of talk to you, to get your insights and guidance on everything that we're doing and everything I've talked about. So thank you very much. Now I think I'm on time. Can someone tell me if I'm on time? Do we have time for questions, comments? Oh, okay, great. Is that a person moving to the microphone or going to the restroom? Excellent.
I'm Peggy O'Kane. Hi, nice to meet you. Can you hear? Okay. Thank you. That was absolutely enlightening and sobering.
Thanks.
So I just want to say we want to work with you, and let's try to figure out how we're going to move forward. What does it mean to be a fire accelerator? Chuck Jaffe was talking to me about that yesterday, and I don't think we understand. But we obviously need some acceleration here.
Yep.
Yeah.
Yep. Yeah. No, that's a great question. So, what does it mean to be a fire accelerator? It means that we call you a fire accelerator. No. No. What it means is fire accelerators
I've been part of other things like that.
It really came. It was part of the lessons learned from first the Argonaut project and then the Da Vinci project, I think, which were basically sort of more organic. Initiatives, bringing together, sort of competitors, a lot of them competitors, focused on a particular use case or a set of use cases, and wanting to, sort of have some focus to accelerate the, sort of the various resources that are important to their use cases and move those forward in a collaborative manner. So it basically, like the Argonaut project, for example, is EHR vendors primarily, but platform vendors, Apple, Microsoft, and then some provider organizations, some large provider organizations, very much focused on provider to provider and provider to patient use cases, leveraging the common clinical data set and saying, all right, so those clinical data elements, what we want to be able to do is say, let's fire enable that so that you can actually query for any one of those elements either as an entire set or one data element at a time, but all focusing on use cases that are going to better enable provider-to-provider exchange or provider-to-patient exchange. And that's kind of an organic group that are all focused on that. And then you have the Da Vinci project, which is payers and EHR vendors and providers, which sort of says, well, there's a different set of use cases. And the reason the accelerator project idea came out was we had discussions, over the time of, well, here we are with the Argonaut project, and that was just first out of gate, it just happened to be. And then discussions with some of the payers of, oh, well, could we have like a payer branch of the Argonaut project, or should we try to fold some of our use cases into it? And then life sciences companies who say, oh, could we have, sort of a little, Argonaut branch of pharma? And then one of the things we quickly realized is, well, one of the things that's been really, sort of effective with the Argonaut project is you have a group of stakeholders who are focused on their use case, and they maintain that focus. And we don't have payers among the steering committee. Why? Because we're focused on provider-to-provider exchange. And if we're going to bring payers in, well, then it's like, all right, well, now all you're doing is expanding that, and you're going to sort of dilute the focus, and that's one of the benefits that we've seen. So Da Vinci picked that up and ran with it and basically said, okay, great, we'll create an affinity around that. And so once we saw that, I think the idea was, oh, there are probably more of these that look more like that, and that it makes much more sense to see if we can take some of the lessons learned from Argonaut and Da Vinci, provide some, sort of a model for them and a pathway for them to be able to say, all right, we want to organize an initiative that's collaboration to accelerate, sort of the usability and the readiness of fire in a particular set of use cases, and we want to be able to try to accelerate that through the HL7 process as quickly as possible without burdening HL7 with more administrative overhead and particularly the volunteers in the working groups. As you know, HL7 is driven by the volunteers, right? And so the concern was, oh, great, basically you're lining up all these organizations who are going to just have these fire hoses pointed at the HL7 process with more implementation guides coming out because everyone's focusing on it now, but no infrastructure at HL7 to be able to accommodate all of that. So that's the notion of the accelerator projects is say, can we help organize these and help those be genuine collaborations to, and then figure out a sort of a thoughtful way to resource them so that they can, sort of make the working groups' lives easier to get those, sort of out of the pipe a little bit faster. So it doesn't give them any privilege or any, sort of accelerated status within the working group process, but it helps to ease the burden and to streamline the burden of, the HL7 process. So there's the accelerator projects which are trying to create artifacts that would come through HL7. And then there's, sort of, it's very new, but the notion of a FHIR community project, which would be organizations who may not necessarily want to put through their artifacts through the HL7 process, but they want to, sort of have some comfort that, okay, we're living by FHIR community principles, which is, sort of openness, IP principles, around open IP, things like that. So you've got sort of those two pathways.
So let me ask a second question. So Chuck was talking to me about FHIR accelerator for quality measurement. I think in our, kind of my level, it's kind of a big picture which may be missing a lot of important detail. But ultimately, wouldn't it be wonderful, and this is part of the goal of our work, if people's actual practice could be captured for quality measurement in a more efficient way, so there's not a separate process. And so when I hear FHIR for quality measurement, and I think that's different from FHIR for delivering health care, tell me about that. Is that maybe a wrong-headed way of thinking about it?
Sure. No. I think it's an important point, and I guess it's more in the subtlety of, because when you think about all of what goes into to quality measures, you have all these other things that that people often don't think about, which is, all right, well, I need the data, and a lot of that data maps directly to the Common Clinical Data Set, which maps directly to what's in the Argonaut Implementation Guide. But what's not in there are things like exclusion criteria, inclusion criteria, exclusion criteria, any other of the measure-specific kinds of things that are going to get me to that measure, and how am I going to get that stuff out of the EHR system? How am I going to get incremental upgrades as appropriate for knowing that, all right, only send the data that's, that's implicated for a particular measure, and being able to do all of that. So there is a greater data call to capture some of those other things that wouldn't necessarily be in just the regular, sort of USCDI or, construct that's used just to make data available on the iPhone. And there's, sort of different kinds of workflows and different kind of triggers you could imagine in the system that are more appropriate to quality reporting than they are for just making that available to an iPhone. So that's really the substance. So there's a lot of overlap. So what we try to do with, with DaVinci is to sort of say, well, let's try to build on the artifacts that are already there. So let's not reinvent the Argonaut Implementation Guide and the Data Query Implementation Guide, leverage that, but then add on top those other things that are really specific to what payers and providers need to understand about those interactions. And I hope that's clear. It's, it may seem esoteric, but on the ground it actually ends up becoming really real. Yes?
Hi, good morning. I'm Zahid Butt from Metasolve, and again, congratulations. A tremendous achievement with such a small staff and resources.
Thanks. Very small, yeah.
Yes. I was struck by your slide, which is similar to our own experience. We do a fair bit of quality reporting, is that you still have to rely 85% of the time on flat files and not CCDs. And we often get asked when we say, well, do you want good results or do you want just go through the motions? When people say, well, why can't you use the CCDs? And say, no, because the flat file, although you don't do the extraction, somebody actually runs the SQL queries and creates those files. It's just a question of who does it.
Yep.
And so, this is now something that we're in the 11th year of meaningful use. And my question is that if that was a standard, and what are the lessons that, based on your insight, because you have so much more experience, that we can learn, because if we couldn't really implement a standard to do some of that basic data exchange, was it a problem with the standard itself? Was it the way it was implemented or not implemented? Are there any lessons we can learn? Because you don't want to, we're as excited as everybody else about the FHIR standard.
Yep.
But if there's a lesson to be learned from a previous standard that after 11 years, only 15% of your quality measures can run off of that, I think there's some insight that I'm hoping you can shed as to what lessons can we learn as we go forward with the
Sure.
fire standard.
Yeah, it's a great question. So one thing I would point out, and it doesn't change, sort of the overall, sort of the overall context of your question, is that, for some of what what I showed there, that's a choice that we allowed them. So for some of them, they said, but that still begs the question of, well, why do they want to do it as a flat file versus a CCD, right? So I'm not taking the question off the table, but if we sort of there are some of those customers that we said, you know what, you really needs to be a CCD, maybe that would get down to 75% or whatever it is. But your point is still well taken. I don't know some of the lessons, I guess, are one, the continuity of care document as it was instantiated in meaningful use and all of that was never really, right? It's not the best vehicle format for quality data aggregation, right? It's got so much overhead related to it as that XML document. The idea, I think of it at the time was, well, that's a great vehicle. There's a standard out there, so we can leverage that, use it for transition of care, and it's machine readable and human readable. So the thought was, that's got some nice usability features to it. And then organizations like us and others started to say, well, gee, if that's what the systems are spitting out, why don't we just try to leverage that, right? So it's unclear that that was ever really sort of conceived as being the vehicle that we should use for transporting data for quality measurement. It just happened to become the one that was most readily available. And we still had issues to resolve of how do you get the appropriate triggers so you're getting a CCD at the end of every encounter, because that wasn't a part of the workflows. So I think that's one thing, right? That it was never really designed for that. The second thing that that I would sort of say is the CCD, because it wasn't designed for that, the focus of the CCDS, the Common Clinical Data Set, and now the US CDI, has never been about quality measures. It's been about what do providers need for treatment purposes at the point of care. And so you've got payloads that are mismatched. And so you have circumstances where the CCD just literally, without custom work, doesn't have the data, or the standard CCD doesn't have the data that you need for a particular measure, fall risk, things like that, right? So then you always end up having to figure out, all right, how am I going to get that additional data, which is a part of the challenge. So that's the second thing I would sort of point to, is that it's not, it was never designed, or the requirements, the drivers of the requirements of the CCD aren't the drivers of quality measurement, and so you have a little bit of a sort of a misalignment there. And then the third thing is that, like we've seen with lots of this stuff, things just get implemented in certain ways that are really hard, that ends up just becoming business issues that you have to work around. And in particular, if you have certain vendors who start saying, we're going to charge you per CCD, then anyone who has the ability to evade that tax will evade that tax. And some of the larger systems, that's what was going on. They literally said, well, I could build a CCD interface, but I'm getting metered on that. Can I just go into the back end and deliver you a flat file that's free, or it's my staff time and nothing else? And so that's one of the unintended things that that we just started seeing out in the field. I don't know if that fully answers your question, but I think all of us are hoping to get to a model where we have something that's much more scalable, hopefully FHIR-based eventually, that's much more sort of natively sort of an intuitively a better approach for for a quality data architecture than trying to sort of just do whatever we can with whatever data is coming out in the CCD.
Yeah, no, I agree with some of your sort of observations that the use case often in interoperability is the one patient needing care in different settings. Right. So that use case is slightly different, or at least there are some additional factors that are part of the quality use case of interoperability. And I think FHIR will hopefully try to address that through QI core and those types of sort of profiling and so forth that are more the quality use case driven. But often people don't think of it in those ways.
Yep.
Right.
And we still have the same issue. I mean, everything I was describing, the FHIR APIs that we have right now are driven by the Common Clinical Data Use Set and US CDI, which has the same issue. It's the same payload. It's just in a better sort of standard. Until we sort of are able to have work like Da Vinci that's sort of saying, well, what are all these other data elements that I was describing before, and how do we mature those and make those available that that we're able to leverage the standard with a better architecture.
Thank you.
Thank you.
Micky, think that was really a very impressive talk, and
Thank
a lot
you.
of great data, which leads me to the things you were just talking about in our desire to get to fire, and that is, I'm wondering, it seems like, and many people who are in the same situation, there's not a lot of people in your situation, but those few that are, you're mapping, right? That you talked about how the front half of that process was really intensive. And so I'm going to challenge you to share that. In particular, because fire actually has something called a map resource. I'm wondering if, as we work through these processes to figure out how to get all those different vendor things to line up, what, one understands that, you met one ETL process, you've met one
Right.
ETL process,
Yep,
but
yep.
I'm not sure that that's necessarily so true as we go to fire. And so I'm kind of on record, Rob McClure, by the way. So
Yep.
can we actually start to create maps for this stuff, document what we've done, and then put those in an environment where, under the right kind of restrictions, we can share them so that we don't have to do this every single time.
Yep. Yeah. No, I mean, I totally agree with you, and I think that would be, sort of the idea. We're always happy to share, what we've learned. A lot of it's really manual, unfortunately, but but we're a nonprofit organization, so we're happy to work with anyone on, sort of figuring out the best models for being able to share libraries, things like that, that others can leverage. And I think that's sort of the idea of projects like the Da Vinci Project, to be able to create a place where you can have those kinds of shareable components.